muscles and nerves to the periosteum.
Do we need an Volkman's canals?
Probably if she's asking that.
Well, yeah, she didn't say it, like, she didn't bring it up, sure.
Thank you for not making me answer that.
Well, I mean, you didn't go.
Yeah, I did. I like the way he says, you're lying, but okay. It's in your notes as well.
No, yeah, it's in my note, it's in the PowerPoint.
Someone asked about Volkman's canals and I went over them. And I pointed them out. Oh, two more. Oh, somewhere around here, though. Oh, why do I smell fried chicken?
It's not fried chicken.
What is it?
It's orange chicken.
Well, it's chicken.
Yeah, it is.
And then,
It
isn't
is
orange
fried.
chicken fried?
Well, I made it. It's kind of not really like fried. Seaweed, I guess. I don't know. Sorry, it's the only thing I had.
No, it's okay.
She's mad because she can't have none.
Well, there's that too. I didn't get my lunch. It's in my office though, so it's all good. Why isn't this going on? See the light's green? There's nothing up there.
I'll try green under the box.
Yeah, it should be green when it's on. And let's see if I can get up there. Hopefully with your right foot. Left foot. No, I can't do that foot either.
Here, let her get up.
else push a button up there?
I'm gonna figure it out.
I'll get you.
I don't think you'll be able to. No offense, but I have to find the button up here. There it goes. Count to 20 seconds. Ta-da. Knew that would come on one way or the other. Okay. Okay, so remember the next 2 weeks we are doing bones in lab. I outlined what you should have done on Monday, so the rest of this lab today will be to go through the things that I didn't cover on Tuesday, and then turn you loose. Now, if you chose to do other things and go over the skull, you're gonna be a bit behind. So you need to make sure you got your skull, your vertebrae, and your sternum and ribs down. Then we're gonna start with the appendicular skeletal next week. So axial this week, appendicular next week. So during infancy and childhood, the epiphyseal plate is stimulated by growth hormone. We talked about that. And what is the epiphyseal plate? What's it consist of?
Hyaline cartilage.
Hyaline cartilage, okay? And during puberty, testosterone and progesterone initially causes that growth spurt. That's how you know your kids are like getting ready to go through the change, because you go, oh my God, I just bought you new shoes last week. What do you mean you're outgrowing your pants? That's what happens, okay? Will cause masculization and feminization of specific parts of the skeleton, and then it will induce the closure of those epiphyseal plates. Okay, and that means those hyaline cartilage templates that are between the epiphysis and the diaphysis turn to bone. So then you don't grow anymore. Okay, so when you get to AMP2, we talk about growth hormone, and one of the side effects if you have too much growth hormone after puberty is to get a disease called acromegaly, A-C-R-O, megaly, M-E-G-A-L-Y. So acromegaly, and that's when you see the growth in width. So if you go to an endocrinologist and you're having some problems, they'll ask you things like, have you noticed a change in your ring size, change in the width of your shoes because your feet are getting wider, your fingers are getting wider, but you're not gaining weight. So that increases appositional growth. It's still going to cause you to grow, but appositional growth instead of interstitial growth. Remember, interstitial growth is growth in length. Appositional growth is growth in width. Okay? So, remodeling units are the adjacent osteoblast and osteoclast, the deposit and restore bone at the periosteal and endosteal surface. There's more osteoclast on the endosteal and more osteoblast on the periosteal side. So we do deposit bone when the bone is injured or added strength is needed. So that's one of the, they basically kind of alluded to that when we talked about astronauts that don't have the weight of gravity and the bones start to remodel, because it's like, hey, there's nothing put weight on it. If you look at when we get to appendicular, we look at the tubercles on the humerus and the trochanters on the femur, we'll see that they're different sizes. And these bones are bigger because they bear our weight. So that stress is being put on them. So that's an important part. It does require a diet rich in vitamin C, D, A, phosphorus, magnesium, and manganese to build bone. And then we have an enzyme, because we know it's an enzyme because it ends in A's, called alkaline phosphatase, which is essential for the mineralization of bone. Okay, so we have to have that enzyme present as well. Now we can see the sites of those with the osteoid seam. This is an area of unmineralized bone. And we'll see a calcification front where there's an abrupt transition between the osteoid seam and the over now if I can say it, mineralized bone. So we have an abrupt difference, and that's we saw that to some extent back when we were looking at hyaline cartilage and the growth. I'll go back real quick. So here's that hyaline cartilage, and then here now we got our osteoid seam, but it hasn't quite mineralized, so we don't see everything that we see, that we need to see. All right. And depositing bone also is the job of the osteoblast. Remember that. Now, bone resorption is accomplished by the osteoclast. We have what they call resorption bays. These are grooves formed by the osteoclast as they break down the bone matrix. And again, bone is constantly being built and broken down. Okay? We need the minerals, the calcium that we've stored out of it. Cells die. We need to replenish those cells, because cells don't live forever, those kind of things, okay? It has, the osteocytes have lysosomal enzymes that digest the organic matrix. So they'll break down the collagen, peptidoglycans, and then acids that convert calcium salts into the soluble forms. So we saw that in the lab on Monday with that, what I call the original rubber chicken bone. Okay, and Bethany brought chicken so that we can think about chicken and bones. Maybe not. Okay, so once it's dissolved, it's transcytosed, so it dissolves it, absorbs it in, endocytoses it, moves it across the cell, and exocytoses it into the interstitial fluid where it's then absorbed into the blood. So, broken down on one side by the cell, it absorbs it in, that's an endocytosis. When it goes across the cell in its vesicle, okay, that's transcytosis, and then it's gonna exit the cell by exocytosis. Those are some of those bulk processes that we talked about with chapter 3. Calcium is necessary, okay? It's necessary for the transmission of nerve impulses, so we'll see that when we get to the nervous system. It's necessary for muscle contraction. We're almost to skeletal muscle, and that's where we talk about muscle for the most part, okay? It's necessary for blood coagulation. We really don't look at that until we get to the blood in AMP 2. It's needed for secretion by glands, so some of the endocrine glands use what's called a PIP, secondary messenger system, to get the hormones secreted. So that's there. We already talked about it being needed for nerve cells, and we use it in cell division as well. So is calcium necessary?
Yes.
See? Milk does the body good. Huh? Pass it on. Pass it on.
And you said it does this by secondary messengers?
Yes. You don't have to know that. You just need to know that secretion by glands.
Specific glands?
Not the specific glands. You don't need to wait till AMP 2. Don't have to learn more than, I'm just giving you examples. So there's two control loops that regulate bone remodeling. So how do we control it? One is a hormonal mechanism that maintains calcium homeostasis in the blood, and that's going to depend on 2 hormones. So parathyroid hormone, causes the bone to reabsorb. It increases calcium in your bloodstream. The other hormone, which is important in children, is calcitonin. And it increases the activity of the osteoblast. And it would decrease the calcium in the blood.
And so this calcitonin, is it stored in your bones? So if you
No.
intake, so it's stored in the bones?
It comes, it comes from an endocrine gland.
So,
Calcitonin is a hormone.
so calcitonin comes from the endocrine gland, and if,
So if you have too much calcium, it'll be secreted and you'll deposit it into your bone.
okay,
If you have too little
Opposite.
calcium, then you'll secrete the parathyroid hormone.
okay, and that'll cause.
And that'll cause
calcium
a
to be
rise of
released.
calcium in the blood.
Okay,
That make sense?
Yes.
Okay. And that's our negative feedback mechanism, right? And then the other we've alluded to is the mechanical gravitational forces that are acting on the skeleton. So rising blood calcium levels trigger the thyroid to release calcitonin. Calcitonin stimulates calcium salt deposit in the bone. And then falling blood levels of calcium signal parathyroid glands to release parathyroid hormone, and it signals the osteoclast to degrade bone and release calcium into the blood. So these two hormones have opposite effects. But I will tell you the most important one as far as calcium goes is your parathyroid hormone. Calcitonin is, it's only big in children. Why would calcitonin be big in children?
they're still growing.
They're still growing. They're still forming bone. They need the calcium to form the bone. Does that make sense? So this just goes through that cycle, shows it to you. And I don't know why there's a line there, but it should say PTH. There. I don't know what happened to that slide. So, rising blood calcium levels, parathyroid hormone actually decreases, and calcitonin increases. I have no way of fixing that either. So the thyroid gland secretes the calcitonin. Calcitonin stimulates the osteoblast to deposit the calcium salt into the bone. Levels go back to normal. Falling levels of blood calcium hits the parathyroid glands. Para means around or near, so these are right near the thyroid gland. Increases your parathyroid hormone, osteoclast break down bone, raise the level of calcium, and then we get back to homeostasis. Not something you need to know, but these two hormones are this semester, these two hormones are considered antagonistic to each other because they have opposite effects. One raises the calcium, one lowers the calcium. The others is Wolff's Law. Bone grows or remodels based on the forces or demands put on it. So long bones, for instance, are thickest midway along the shaft where bending stress is the greatest. Curved bones are thickest where they are most likely to buckle. Trochanters attached to the big muscles that control your legs, okay? Whereas the tubercles that are found on the humerus, those arms are straight, not as, they don't have to carry as much around. They're weaker muscles comparatively to legs. And so those have different sizes based on the stresses that are put on them. Trabeculae and spongy bone form along the lines of stress. And then we said the large bony projections occur where heavy active muscles attach.
What's a tubercle run?
Tubercle or trochanter, depending on whichever, if you're in the humerus or the femur. And we'll look at those next week with the appendicular skeleton. That make sense? So y'all haven't seen those yet, but we'll look at them. The last little bit on the general overview, we do not really consider, because you spend 2 weeks on labs, we're not gonna go over the specific bones. Does that make sense? So this is just some basic general information about bones, and then actually naming the bones is a lab thing. Now, I can ask you, which of the following, for instance, is a long bone, which of the following is a short bone? And by the test time, you should know that, okay? Does that make sense? So, but I will not put a skeleton on the lecture test and say, name this bone. Does that make sense? So, okay, so bony fractures are classified the position of the bone ends after they fracture, the completeness of the break, the orientation of the bone to the long axis, and whether or not the bone ends penetrate the skin. So we have non-displaced and displaced. Non-displaced bone ends retain their normal alignment. Displaced, they're out of their normal alignment. Then we have complete, incomplete. Complete is broken all the way through. Incomplete is only broken through one side or the other side, but not both sides. Because we have two sides of compact bone, for instance, long bone, it only gets one side, that's an incomplete or a green stick. Then break the whole thing. And then we have a linear fracture, which running parallel to the long axis. Most of them go horizontal. Transverse is a fracture perpendicular to the long axis. Compound means it's open, they penetrate the skin. Simple means they do not penetrate the skin. So a lot of, usually they'll classify these as it's a simple transverse fracture. So you use multiple descriptive terms to identify the type of fracture. Comminuted means there's more than two fragments, so it's broken into 3 or more pieces. Spiral means that it's a ragged break where the bone is excessively twisted, like with, throwing that ball, they turn their arm. Spiral are very common sports injuries. Depressed, the broken bone portion is pressed inward. These are very common in skull fractures. So break the bone and it goes inward towards the brain. Don't want that. Compression, bone is crushed. This is common in vertebrae. So they sink down. Epiphyseal, the epiphysis separates from the diaphysis along the epiphyseal line. And when it does that, the cartilage cells die. And then again, a green stick is an incomplete fracture. So one side breaks and the other side bends. So we've got some examples up here. So A is showing you a closed fracture here. Here's an open, so it's penetrating through the skin. Here's a transverse, going straight across. Here's a, like that one's a spiral, I can't see it real well. Spiral. Then here's a comminuted, so there's more than two pieces, so there's 3 or more. That this is what's called an impacted, similar to the compression fracture. Here's a green stick, so only one side is broken, and then this is an oblique, so it's going at an angle. So here's the other picture that I put up here. So here we see a comminuted, so we see several pieces up here. Kind of reminds me of my doctor's ankle. She's Dr. Daughter's ankle. So we see a piece here, there's a piece over here, a piece along here, so we've got several fractures in here. And this is a fracture of the tibia, fibula and the tibia. So there's three pieces here, here, and then this one's a simple fracture. Here's the compression fractures. You see how things just kind of fracture because this bone is porous, and so the turbiculae in the middle of this is breaking down. See what happens here? Very common with osteoporosis and elderly people. I have someone at my church right now that's in because she coughed too hard and broke one of her vertebrae in her back. She's like 90. Still sings in the choir. Maybe not after this. So, but you can see what happened to the distance here. And we get some of that anyhow because, you know, we shrink as we get older. Here's the spiral, so we see it's a ragged break. See that here, so it goes this way, then it comes over here. Again, common sports injury, here's a epiphyseal, so we break it off from the diaphysis. So the epiphysis and diaphysis break off, so you see it here. Here's the epiphysis, here's the diaphysis. Depressed, not a huge movement, but it's moving inwards here, hard to see, so that's common. Skull fractures. Here's a green stick, so you can see it's only broken on one side. See this side bent and this side broke. That's more common in children. Why? Because they have what? No, they have more collagen. Okay, so they have a lot more collagen. Okay, then we have the stages of our fracture healing. So here we have our fracture. The first is the hematoma, the big blood clot that forms around it. Okay, then we have the spongy bone forms a fibrocartilaginous callus. Then we get our bony callus. And then we have our remodeling. Those are our 4 stages. Hematoma, fibrocartilaginous callus, bony callus, remodeling, and then it's back to normal. Okay. So here's the hematoma. So the torn blood vessels, they hemorrhage, we get that big blood clot, site becomes painful, swollen, and that's a lot of times why they don't do surgery immediately. Like, you got a broke foot, got a broke leg. Well, we can schedule you for next week. You're like, what? So they want some of this to kind of clear out, makes it easier to repair the bone. Then we have a fibrocartilaginous callus, so we get some forms a few days afterwards. Capillaries begin to grow in. Phagocytic cells start cleaning up the debris. This is also called the internal callus. It's made of fibrocartilage that comes in at the, and forms a bridging between the broken ends. That's remodeled into bone. And then we get our bony callus. Okay? So the fibrocartilaginous callus forms when the osteoblasts and fibroblasts migrate to the fracture and start to begin to restructure it. So that's our model, our template. Except instead of using hyaline, we're using what? Fibrocartilage. Okay? Then the osteoblasts begin to form the spongy bone. And the osteoblasts further the capillaries, secrete externally bulging cartilaginous matrix that later calcifies. So then here we've got bone that's been formed. So we get some turbiculae within that fibrocartilaginous callus. And the bony callus starts, it's not there till about 3 to 4 weeks after the injury, and it continues until a firm union is formed, which takes 2 to 3 months. It takes forever to heal bones. How many people have had a broken bone? It's not fun, is it? Seth, you haven't had one?
No.
Why do you raise your hand? He's my bone guy. Is that why you're so interested in bones?
No, I was trying to make a good grade in this class.
There you go. Okay. I thought he wanted to be an SI.
No.
Okay, so here's the, let's do that, because I was gonna recommend you,
I'm busy.
but it would be next semester. Think about it. You got a gift. So here's the bone remodeling. So, and we just basically getting everything back the way it was in the first place. So we formed a new, area in the medullary cavity, the fracture's healed, and the fracture is actually stronger after it's healed than it was. Most likely not gonna break it in the same place again. Doesn't mean you won't break that arm, but it will be in a different place. Does that make sense? Okay, some homeostatic imbalances that occur, we can get osteomalacia. Our main system is pain when weight is put on the affected bone. It's caused by insufficient calcium or a vitamin D deficiency, and that's why you gotta go, to the drugstore and you'll see, vitamin D with calcium, or calcium with vitamin D, so I said that backwards, right? Or you may go to the doctor and they'll tell you to get some, D3. Ladies, that will be you eventually. They'll be telling you to take your calcium, okay? Because women, due to the effects of estrogen, and the estrogen is no longer there, parathyroid gland's like, hey, no one's, because these hormones all work together, and we start breaking bone down very easily, okay? I don't remember if I put that in there. Rickets is bones of children are inadequately mineralized because they have more collagen, they have very soft, weakened bones, and so they get bone legs and deformities, and it can occur in the pelvis, the skull, the rib cage. That's another reason, because children are so flexible. So if you're come from cowboy parents, they're bow-legged, and they get their legs around the horse all day, and they have that bow-legged because that's how it formed based on the stresses.
Would that happen only after birth? Because of the stresses, or?
Yes. Okay. We don't see rickets because milk does the body good, and we got lots of milk, and kids get a lot of vitamin D. There's also, what's it called? I'm blanking on the name of it. Women, infant, and children WICs, I think maybe it's what's the acronym for it. So if you're financially strapped, you have some problems financially, you can get on the WIC program, and they get you like milk and stuff if you have children. So it gets to make sure you get the things that you need so you don't develop the rickets or other problems. So I guess I did not put it in here, so I'm gonna show you some pictures of rickets. So we can see what happens when you don't get enough vitamin D, calcium in your diet, so you can't ossify the bones. Here's the x-ray, so you can see the bones have boned out. There's some better pictures. Lots of pictures of the x-rays, but
So it doesn't only happen in the legs, it can happen in
Yeah.
your hands also, in your arms also?
yeah. With the better one, I saved it, but I don't have to do it. Look at that, push on the baby's head, horrible. There's a whole family. look what's happened to the back here. Let's see. No, did the wrong thing. Right, one more time. Hit the right button. Save my soul. People, right there. Not really showing what I wanted. I had one with a sternal. Anyhow, I guess I can't find it now, so. Maybe they took it out, who knows?
Oh, it's right in the sternum.
Uh-huh. You can see the malformation in the chest cavity.
So is that like, I remember years and years ago, on America's Financial Video, some guy was eating cereal out of his dip in his chest. Is that?
It could have been. I mean, there's always lots of causes for certain things. You see symptom, but what's causing it? So I couldn't tell you, never saw it. And that's one of the things that you kind of have to realize is there's symptoms and then there's diseases. And symptoms can fall into a variety of diseases. Like diarrhea does not have one thing that's causing it. It can be lots of things that can cause it. Vomiting's the same way. Malformations in the mouth, same thing. But you see a symptom. And I've tried to, especially in AMP2, trying to make people understand that just because you see one thing doesn't mean that's what it is, okay? There's a difference between symptoms and diseases. Like, one of the symptoms of hyperthyroidism in people is this exophthalmosis, which is a bulging of the eyes. Don't go around asking people if they have bulgy eyes if they have Graves' disease. I did that once. Lady at my church.
Oh no.
No, they always ask me, wanted to test me for that. And I had a student that went to my church once, and I made that comment in my AMP2 class. And she goes, "I know who you're talking about." But she didn't have Graves' disease, so there's always more than one thing, and all it does is lead you on a pathway to those things that can cause it. So, osteoporosis is a multifactorial disease, so it's just a disease where the bone resorption, the bone breakdown outpaces bone buildup or deposit. Most of your calcium that you need for your body to help your body is usually stored by the age of 30. Okay, within your bone, so you really don't want to, you're not taking your calcium, you're not 30, start taking your calcium, okay? Spongy bone of the spine, of course, is the most vulnerable, occurs typically post-menopausal women, and the bones become so fragile that again, sneezing, coughing, stepping off a curb can cause fractures. there are some diseases that cause you, autoimmune diseases that cause you to break down collagen in your body, and so you'll see some people like have the handicap stickers so that they can be close to the building, because walking even with shoes on concrete will cause fractures in their feet. That's in lupus. The systemic lupus breaks down collagen, and collagen's found everywhere. It's found in your bones, it's found in your skin, it's everywhere. So, not a good disease to have. So we treat it with calcium and vitamin D supplements. Also, you increase your weight bearing exercises, that will help as well, because bone does what? It remodels based on the stresses that you put on it. So if you start lifting weights, you don't have to lift heavy weights, but just a regular routine of like 5 pounds. Darla, did you say that?
I think even just your body weight.
Okay, so your own body. She's a therapist, so throw that out there. So usually I see them when I go into the gym, it's like 2 pounds, here, just do these.
It doesn't take much.
It doesn't take much, but it does help. You can take estrogen replacement, which helps slow blood loss. Of course, it has its side effects, because estrogen has sort of been linked to breast cancer. Okay, natural progesterone creams also promote new bone growth, and then statins increase bone mineral density. So taking things like I'm blanking on the name of the drug. Can't think of it. But the statins, that classification of drugs, will increase bone mineral density.
Like a torvastatin?
Yeah. So, developmental aspects, again, there's 3 cell types. There's the ectoderm, endoderm, and mesoderm. Those are the germ layers. As you're developing, the mesoderm gives rise to the mesenchymal cells, and the mesenchymal cells then produce the membranes and cartilages that form the embryonic skeleton. Okay, it ossifies at a predictable rate, so that's how you can judge the age, fetal age, and you know, it's like, when was your last period, ladies? And you're like, what? I don't know. Most women don't keep track, don't write it down, then you forget. So they can do an ultrasound and figure out your fetal age and give you at least a guesstimate when you're going to be due, okay? At birth, most of the long bones are well ossified, except for at the epiphysis, and also the skull bones, except at the fontanelles. Age 25, nearly all bones are completely ossified. How many of you get 25 now? Under 25. Oh, so not 2,500, sorry. 25, under 25. Anyhow, so in old age, bone resorption does predominate for everybody, male and female. There is a single gene in your DNA that codes for vitamin D docking that determines the tendency to accumulate bone mass early in life. And so that's one of the things they look at to see your risk for osteoporosis.
Would that have anything to do with MS?
No,
Because of a genetic.
to my knowledge, no. That's a multiple sclerosis, and that's a muscle disease.
Then I think they say lack of vitamin D in early childhood can cause, so would that?
Well, they do know that MS actually occurs more in people in northern environments that grew up in northern environments. So, and that may be due to lack of sunlight, which is needed to activate vitamin D, convert it. So. So again, sunlight is your source of vitamin D. The other place that, is the kidneys. Where it converts it to the active form of vitamin D. Peak bone mass, females that are around 30 years of age, males, and around 20 years of age. And then the decrease in bone mass, males decrease it slower than females, they have much bigger bone mass, and that's because they have this nasty hormone that's called what? Testosterone. Ladies, they got it easy. Guys, you're lucky, okay? I mean, Seth, you're lucky. You're the only guy in here today. He goes, really? So, if you look at this, testosterone gives guys bigger chest so they can bring in more oxygen, gives them more muscle mass, it gives them like decrease in their bone density, and without stress they would live longer than we females. Okay, we get pregnant. Okay, we go through menopause. Look at this. Here's menopause around 55 to 60. We get loss of estrogen, and look at our bone mass. It goes boom. Okay. So, we need to really work on that bone mass early. Those of you that raised your hands that were under 25 need to really work on that. Those of you that are over 30, over 25, start doing your wait list and try to affect it that way. Take some calcium and vitamin D. Okay. Changed the computer out last semester, so I don't have all my PowerPoints on it. Let me get it real quick. Any questions from anybody?
When can we look at our lab test?
After lab? I told you could look at it before class or after lab. I had several people before class.
Skip 7 and 8, go straight to 9.
Ooh. I think that's right.
Oh, I don't have it.
Well, seven, I know, is the bones themselves. So, yeah, 7 and 8 are the bones themselves, but we do them last. Okay, it's divided, in this book is divided into action lab and then appendicular.
So our test will only be able to track those.
Your next test is over bones, joints, and muscles.
So 6, 9, and 10.
Yes.
What topic? 6, 9, and 10.
And I think that's on your syllabus. Okay, so I think everybody would understand that without these articulations or these joints, movements would be impossible. So if you have somebody out canoeing, they could be down there at Fort Worth, at that little canoe shack there at the I think it's Fort Worth Pavilion or something. It's over there by the Trinity River campus, right behind it. Except it's not at the ocean, which would be lovely, wouldn't it? Okay. But they are the weakest part of the skeleton, and a joint or an articulation is a site where 2 or more bones meet. And it has basically 2 functions. One is to provide motility, and the other is to hold the skeleton together. Otherwise, we'd just be, I don't know if we could even walk, because there's a joint here at your hips, right? But think about it, if you didn't have your knees, you'd be walking like stiff-legged. Not in your arms. But we couldn't even do that if we didn't have the hip joints, and pelvic joints, okay? So you gotta have those. Now we classify them both structurally and functionally. So structural classification focuses on the material binding the bones together and whether or not a joint cavity is present. So we have a fibrous, which has fibrous tissue that holds the joints together. There's not many of those, but they are there. We have cartilaginous, which means there's cartilage between the joints. And then synovial means that we have a joint cavity. And these are our 3 classifications. So fibrous, example of that would be your tooth in its socket has a fibrous joint. Cartilaginous, your pubic symphysis, between the 2 not between 2 vertebrae, but between the 2 pubic bones, or even between the vertebrae. That's a fibrocartilaginous joint. And then synovial, that's most of your bones. So the hip bone, elbow, shoulder, all of those are synovial. Okay? Now, functionally, we can classify whether they are immovable, slightly movable, or freely movable. So, synarthrosis means they're immovable. Amphiarthrosis, amphi means kind of in between, okay? So they're slightly movable. And then diarthrosis are freely movable, and all synovial joints are diarthrosis. So let's go through our fibrous first. These are bones joined by fibrous tissues. There is no joint cavity. Most of these are immovable, and there's 3 types. There's sutures, syndesmosis, and kyphosis. Sutures are found in the skull. Syndesmosis is found between the radius and ulna and between the tibia and fibula. And gomphosis is found in your teeth. So this picture shows you the suture lines that we see within the skull. The one between the parietal and the temporal bone is called the squamosal suture. And between the parietal and the occipital is the lambdoidal suture. Here's between the radius and ulna, so we see this syndesmosis. There's just a little interosseous tissue membrane between the two. And then here's the gomphosis between the tooth itself and its socket. And that tissue has to be broken down for them to extract that tooth. So sutures again occur between the bones of the skull. They're composed of interlocking junctions that are completely filled with connective tissue fibers. They allow the bones to be tightly joined, but they're not ossified yet. And that allows your head to grow. Could you imagine you would have to have people say Beetlejuice to you 3 times? Because you would have this big body and you have this little bitty skull, because there would be no place for the head to grow without the sutures. So about middle age is when the skull bones are completely fused, and at that point those sutures are called synostosis. So we see that here. Here's our suture line, that fibrous tissue that's connecting it. Another picture here. Here's the lambdoidal. Here's the squamosal suture. Here's the coronal. What does coronal mean? Remember we used coronal?
Front and back, right?
Yeah, front and back. So that makes sense that that's called the coronal. It's dividing the head in the front and back. So it's between the frontal bone and the parietal. Notice these are all basically between one bone and the parietal bone. So temporal, squamosal, occipital, lambdoidal, and then coronal up here between the frontal bone. And this shows you the fontanelles that occur in fetuses and infants, So there's the anterior fontanelle. There is a posterior fontanelle back here, down here, sorry, get my pointer in the right place. So that we'll be able to see that on the fetus skulls that we have in lab today. So syndesmosis are connected by a fibrous tissue ligament. Movement varies from immovable to slightly movable amphiarthrosis. Not a huge movement, okay? And again, examples are between the tibia and the fibula and the radius and the ulna. So this one shows you the syndesmosis between the tibia and the fibula. So we see this little ligament that's here. That's a syndesmosis. And you can sprain that ligament. Then our last type of fibrous joint is the gomphosis. It's a peg and socket type of joint. It's between the tooth and its alveolar socket, and there's a fibrous connection. It's called the periodontal ligament. And it's very strong. So you break it down, you can remove the tooth as a whole tooth. If it fractures, yeah, there's tooth left in there. That's when they start digging around.
So does that break down, like when you're losing your baby teeth,
Yeah, it
Yeah,
resorbs.
so it just breaks
The
down?
root of the tooth is resorbing as the adult or permanent tooth is coming up. So the tooth is resorbing, the ligament not not so much. It's the tooth getting weaker and disappearing the root. Does that make sense? And in the middle, and at the same time, the permanent tooth is pushing it up.
Are babies born with all the teeth they'll ever have?
Yes. And some people are born with extra teeth, and some people don't have all the teeth. How many people were born without wisdom teeth?
Very small. I wish.
Yeah.
That was the most painful thing I ever did. If they're extra teeth, like super weird.
Yeah. And then some people have room for the wisdom teeth. Most of us don't. So if you find someone that does say, well, you just gotta take naps. Because basically that's it.
They still don't know how to clean them.
No, they're hard to clean.
Yeah, that's why I should go.
So, and sometimes they're partially erupted. So, a lot of times they're impacted down and they don't express out, and that's why they have to be removed because you don't have enough space. Sometimes they're partially erupted, so they're kind of coming up, but they kind of hit up against the back tooth. That's what mine did too. Mine were partially erupted, and I didn't have my wisdom teeth removed till I was in my 40s. And then they were simple extractions because the roots were all fused together. Like, let me up for something else? Take that tooth out. Okay, good, it's done. Went back to work, they go, what? Yeah, I had my wisdom teeth out today. What? Because everybody gets them out all at once, and then it gets a big, swollen face, and like, oh.
That was me.
It's most people.
Yeah, I found that the pain medicine, I did not like it at all, I just got it. Just made me sick.
Nobody likes pain.
Well, that medicine gets you like goofy and just like it.
So then that was our fibrous joints. There's 3 types. What are they? What did we name? The fibrous joints, 3 types. What were they? Gomphosis, syndesmosis, and the suture. Okay? Now we have cartilaginous joints. Again, they lack a joint cavity. The only one that has a joint cavity is your synarthrosis. Synarthrosis. So, the articulating bones are united by cartilage. There are 2 types, there's synchondrosis and symphysis. So the spar or plate of hyaline cartilage that unites the bones. All chondroses are synarthrotic, means they don't move. So the epiphyseal plate, which is connecting the epiphysis with the diaphysis, is considered a synchondrosis. And the joint between the costal cartilage of the first rib and the sternum, so way up here. So you can feel it first rib, you go down off your clavicle, and about right here is where you find it. Okay, it's right below that clavicle. So this is showing you your synchondrosis here. Now this is a symphysis, this is our other type. So this is the pubic bone, okay? And the baby's head has to go through here, so a lot of times when women get pregnant, most of the time, this is gonna widen, okay? So that the baby's head can fit through there. That's one of the things that's part of growing up is the pubis widens. The pelvis widens. And this is gonna make it a little bit wider. Doesn't always go back to the way it was. So if you have a child, you may notice that your jeans don't fit, even if you're back to your same weight. Like, why are these jeans a bit tighter? The synchondrosis here in diagram, and then here, coloring diagram between the first rib and the sternum. Now, the upper part, since I have this here, this upper part of the sternum is called the manubrium. The bottom is called the,
Body of sternum,
well, the bottom of the sternum is called what?
xiphoid.
Xiphoid process, okay? So we have the top is the manubrium, the very bottom is the xiphoid, and like Seth said, because he loves bones, the middle of it is called the
Oh, body of.
the body of the sternum. So, manubrium, body, xiphoid. Most people know the xiphoid because they're like, oh, they mean the xiphoid process. Or you take in CPR and they take 2 fingers above the xiphoid, feel for the xiphoid, get 2 fingers above it, and then do your chest compressions.
Is that what they say?
Actually, defibrillator is best, but you know, hey, if you don't have that, then you're doing CPR and praying for the best. Okay, these are amphiarthritic joints, so they're designed for strength and flexibility. Again, these include our intervertebral joints and the pubic symphysis of the pelvis. So, here's the vertebrae. These are the fibrocartilaginous intervertebral disc, and that's what they mean when you slip a disc. This is now pushing up or down. So it's no longer in here. And so that just messes the whole thing up, and they're painful. Now you got kind of bone on bone. Bone on bone is not fun.
Do we not just call them intervertebral disc? We have to use the fibro.
Well, it's a fibrocartilaginous, is what makes up the disc. Fibrocartilage does.
Yeah, I know that.
And then it's, if you look up here, it's also called the intervertebral disc. Does that make sense?
Yeah, so it can call it either.
Basically, but in normal terms, you're gonna be called intervertebral, then what's it made up of? It's made up of fibrocartilage.
Will you take either one on the test?
Depends on how the question's asked. Obviously, you can't say intervertebral disc if I say, what makes up this structure? The last is our synovial joints. They're all diarthrosis, they all have a joint cavity. So all your limb joints, and really most of the joints in your body, okay? So they basically allow for smooth movement, so here's that joint space. It's gonna be filled with synovial fluid. The ends of the bones are gonna be covered with hyaline cartilage or articulating cartilage. Again, that's back to, you know, how's the question worded, whether you can say articulating cartilage or you say it's hyaline cartilage. Does that make sense? So, then we see our synovial membrane here. That's important because it secretes the synovial fluid. And then to the outside of that, we're going to have our articular capsule. So there's a capsule that comes around to the outside. Articular means what? Basically a joint capsule. Okay? And then many times after that, we'll have some ligaments that hold that together. So that'll run alongside here. Lots of different types of synovial joints. The first one that we have up here is a pivot joint. And we can see that in 2 places. Okay, pivot joint is found around the radius and the ulna. So the radius is on the side of your thumb. Okay, so bring your thumb up, and you can, without moving the elbow, you can radiate your thumb around. See that? So it's radiating around the ulna. That's a pivot joint. It's also found between the first and second cervical vertebrae, the atlas and the axis. Allows you to do this. So you can pivot your head without moving the rest of your body. Hinge joint is the other joint at the elbow that allows you to go like this. And notice you can't bring your arm back any further, can you? You can think of hinge joints with your knees. You can bend them this way, but you can't bend them, you can't take your straight leg and bend it, touch your toes to your femur.
You can, you're very.
It stops, it's like a door hinge. Okay? We also find it in our fingers. Notice your fingers don't bend backwards. You move the wrist backwards a little bit, but the fingers are straight. They can bend down here, make a fist, but then they come out, okay? The next one is basically a saddle joint, and that is between your thumb, base of your thumb, that first phalange of your thumb, and the metacarpal joint. And that allows you to do this. I should try it with this finger because I have arthritis in this thumb, it hurts. Plain joints are found between the tarsal bones of the foot. They're also found between some of the carpal bones of the wrist. And they allow gliding movements. So you just kind of glide across each other. Then we have the radiocarpal joint at the wrist, which is a condyloid. That's why we can do some of the, we can do this, we can spread our fingers, we can bend them, so it has more movement than just a hinge joint does. And the last one is the ball and socket joints that we see in the shoulder joint and the hip joint, hip between the femur and the pelvis, and the shoulder joint is between the head of the humerus and the scapula. So we touched on those synovial joints, but we'll talk more about them. What is today? Thursday, Tuesday. So we're gonna last now.